Hello again. My name is Dr. Rakesh Jain, and it's my pleasure to welcome you to this session titled Tardive Dyskinesia Across the Complexity Spectrum, from Quality of Life Improvement to Novel Treatments. This activity has been supported through an independent educational grant from Neurocrine Biosciences and Teva Pharmaceuticals. While I introduce the speakers for this session, if you haven't already done so, please take a moment to answer the polling questions. You should see them on your screen. Depending on the device you're using, the questions will either appear to the right of the live stream or below. These questions will be asked again at the end of the program, and we definitely appreciate you answering the polling questions. It's my pleasure to introduce you to our two excellent speakers for this session, Dr. Craig Chepke and Mr. Jeremy Schreiber. Dr. Chepke is the Medical Director, Excel Psychiatric Associates, Adjunct Associate Professor of Psychiatry, Atrium Health, and Adjunct Assistant Professor of Psychiatry at UNC School of Medicine. And Mr. Jeremy Schreiber is Adjunct Faculty, West Liberty University in West Liberty, West Virginia. You can type in your questions for the presenters in the Q&A box to the right of your screen, as well as upvote questions submitted by other attendees if you want to see their question answered. We will try to answer all of the most popular questions with the time remaining at the end. So without further delay, let's begin the session.
Hello, everyone, and welcome to today's TD 360 session, Tardive Dyskinesia Across the Complexity Spectrum, from Quality of Life Improvement to Novel Treatments. My name is Dr. Craig Chepke, and my co-presenter today is Mr. Jeremy Schreiber. We do have some disclosures to give you, if you can see them listed here, if you have any questions about them. In terms of the presentation, we will be discussing some off-label usages of certain medications and treatments. This presentation has been independently reviewed by peers for balance, and any video clips that have been used were obtained with patient permission. The goals for today's session are to look at the impact that TD has on patients and what barriers they may be facing to receiving care. We're going to look at the key clinical trial data for the two approved VMAT2 inhibitors, and then integrate the knowledge that we have of diagnosis and treatment of TD into our treatment plans. So Jeremy, please walk us through the impact that TD has on patients' lives.
Well, thank you very much, Dr. Chepke. I really appreciate that. When we think about the impact of tardive dyskinesia, we need to think about what is tardive dyskinesia. You know, this isn't acute dyskinesia, this is tardive dyskinesia. And by definition, it occurs late. So, and it has dyskinesia, which are going to be kind of these distortion of these voluntary movements or these hyperkinetic involuntary movements. So it is this late occurring hyperkinetic movements that happen to our patients. Now, our patients can develop tardive dyskinesia after they are on dopamine receptor blocking agents. And it can start as soon as a few months after a few months of treatment, but oftentimes it's going to occur after a couple years of treatment. However, it should also be noted that tardive dyskinesia can even occur in patients long after they've stopped their antipsychotic regimen. Now, in terms of severity, it can range from mild to severe and even be disabling. When we think about the symptoms of tardive dyskinesia, we need to understand that these are generally chronic and irreversible, and they may wax and wane over time. When we look at the impact of tardive dyskinesia, we need to understand that TD can have truly an effect on adherence to other medications. When we look at the antipsychotic class, we can see that patients will discontinue antipsychotics for several reasons: sedation, prolactin, metabolic reason. But the most common reason, including TD here, is EPS or agitation. It is the motor side effects that are most likely to have our patients stop their antipsychotic medications. When we think about utilization of healthcare resources, this study was done in veterans with tardive dyskinesia. And what you're seeing, when all things are held equal, with the exception of having a diagnosis of TD, is that patients with tardive dyskinesia are more likely to receive more day supply and two or more antipsychotics. In addition, they're more likely to receive benztropine, which we know doesn't help with the symptoms of tardive dyskinesia, in addition to having a higher Charleston comorbidity index and higher incidence of medical hospitalizations. TD is also going to impact our patients' lives more negatively. When we look at patients with tardive dyskinesia, we can see a lower quality of life, increased social withdrawal, and lower mental and physical functioning, regardless of the underlying diagnosis. This slide here presents a heat map. And what I kind of want to frame this out to you all here. What you're looking at is on the red is strongly disagree, the orange is disagree, light blue is neutral, blue is agree, and green is strongly agree. And what this is a representation of are actors portraying patients with TD or without TD. And they had people determine what they would do with these patients in terms of if they were applying for a job. So the respondents of this were people giving their responses in aggregate about how they would reply to these particular patients that had TD or didn't have TD. And you can see that if the candidate was dressed appropriately or that they thought the candidate would be suitable for a back office job, most of the respondents viewed people with or without TD very similar. When we start to look at things, the more nuances, such as I'd be interested in learning more about this candidate, you can see that people with TD fared more poorly in terms of how they were responded to. When you look at, I'd be willing to suggest that others in my company should interview this candidate, you could see again that patients with TD fared more poorly. And if you really look at this and you think to how the respondents replied, I think the candidate would be suitable for client-facing jobs, whereas 47% of the time, they're responding that the patient with TD would not be suitable for client-facing jobs. So this is much more than a cosmetic illness. The key learning point here is that patients with mild to moderate TD may experience social and professional stigma as a result of how their symptoms are perceived. And with this being said, we're going to take a look at a video assessing the impact or examining the impact of TD.
The tongue movements are things that are unusual that people kind of stare at and wonder what's going on with you or why that's happening, or it embarrasses them and they withdraw or are judgmental.
I have difficulty swallowing. I cough a lot. I choke up a lot, even with water.
Living with it is not easy, especially when you don't understand what's going on and what's happening. Because it wasn't understood in the whole deal. It was hard for my family to understand what was happening to me and what was going on and why is Dad nuts.
I have to schedule an appointment.
Because I have to schedule his appointments.
I can't answer the phone.
You can't answer the phone. The way it's kind of impacted our marriage, it does have some negative impacts. It's kind of how I see my husband. So he used to be like my protector and my best friend. And I still see him that way, but it's taken some work to see him that way still. Because when it first happened, I felt like I had to take care of him, and I felt when people were not nice to him, I had to defend him, and it went from being like my equal to almost being like my child. And once I realized that wasn't right, it's not like just because someone can't speak doesn't mean that they're not mentally there. And so now it's just trying to get that point across to everybody that we know. And people have stopped talking to us. We have lost a lot of friends, and that's fine. It's just been really hard. So it's taken a lot of work and therapy for both of us to kind of be okay with accept what we have.
Wow. Well, what a great video about the impact of tardive dyskinesia. Now that we've gone through the impact, I'm going to turn it over to you, Dr. Chepke, to discuss recognizing tardive dyskinesia across the spectrum of severity.
Thank you, Jeremy. And I agree, those videos were heartbreaking. I don't see how anyone could deny that there is definitely a stigma associated with tardive dyskinesia. We all know the classic song made famous by Louis Armstrong and others, "When you're smiling, the whole world smiles with you. But if you have TD, the whole world can turn away from you." So the first step to recognizing TD is understanding just how prevalent it is. The prevalence of TD is much more than we might like it to believe. People who are currently on first-generation antipsychotics, estimated 30% of those individuals are likely to have TD. Currently on second generation, potentially with use of first generation in the past, 20%. And then if someone has only had second generation exposure, no first generations ever, estimated to be 7%. Although I would caution, how do you really know your patient's never been on a first generation? I mean, my patients often don't know what meds they took this morning, let alone what they took 1, 5, or 10 years ago. So we should probably assume that most patients that we're treating who have chronic issues have been exposed to first generations in the past. So that is a reduction from first to second generation in terms of overall prevalence. The annualized incidence, the new cases per year, also saw a decline from about 6.5% to 2.5% moving to second generation antipsychotics. So in each case, we're roughly seeing about a 3-fold reduction in prevalence and incidence, and that's good, but that's certainly not negligible, especially because to determine how many people are at risk for TD and are likely to have it, we have to think about how many prescriptions are we writing. And unfortunately, that has increased dramatically. Roughly correlated with the era of the second generation antipsychotics, the number of prescriptions have boomed. This study showed from 1997 to 2018, just over 10 years, that there was about a 3-fold increase. Now think back, I just said there was about a 3-fold reduction in incidence, but we've got a 3-fold increase in prescriptions. So that totally cancels out the advantage that the second generation antipsychotics conferred in terms of tardive dyskinesia risk, roughly. So really, the ultimate legacy of SGAs might be that more cases of TD overall than less, because this number is not likely to go down, is it? We're only prescribing more and more antipsychotics each year. So truly, the rising tide of prescriptions is lifting the wrong boat of TD. What we have to do is step up our monitoring. Recent guidelines have addressed this. The APA treatment guidelines for patients with schizophrenia had a very good section dedicated to tardive dyskinesia, which we can apply to patients without schizophrenia as well, I would believe. What it recommended were regular assessments with structured exams. Now you could use the AIMS, you could use the DISCUS, whatever you want. And by regular, they mean at least every 6 months for people at high risk. We'll get to the risk factors later. And people not at high risk every 12 months. But then taking a step further, I like the guidelines down in the bottom right. There was an expert consensus panel convened using a Delphi process. And these were people who had tremendous experience with TD and movement disorders, neurologists, psychiatrists, and their guidelines state that, sure, you got to do the structured exams like the AIMS, but that can't be it. Because who's got time to do a structured exam every visit, right? What you should be doing every visit is a semi-structured exam that you can carve out 1 or 2 portions of something like the AIMS or DISCUS and just do that instead of doing the entire exam, and combine that with other observations, discussion with the patients and any care partners or friends who might be involved in their care, and do that every patient, every time on any antipsychotic. This is a quote from one of my heroes, Professor Owens over in Scotland, and I've adopted it as my mission statement when it comes to looking for TD, that we have to assume that any patient on an antipsychotic is probably going to have some movement disorder issues, not assume that they're going to be fine. So we need to be proactive, and we need to seek out those movement disorders and not wait for them to manifest to us, find each and every one as early as we possibly can. These are the risk factors for TD, and if you only take one away, I want it to be the one in purple, which is why I visually highlighted it, that age. Age is the single most important risk factor for TD. It skyrockets by 3 to 5-fold once a person crosses just 50 years of age. This is not most people's definition of elderly or geriatric, is it? But when it comes to TD risk, it is. And then once you cross the 65-year-old threshold, it goes up even further, 5 to 6-fold. So take that away if nothing else, but there are others listed in blue across the bottom. Importantly, I'd point out people with mood disorders are more likely to develop TD than people with psychotic spectrum disorders, contrary to prior beliefs. Also, alcohol or substance use disorders. We all see patients that have substance use disorders in parts of our clinical work. These people are at higher risk, as are those with intellectual disabilities, CNS injuries like TBIs, many different characteristics. In terms of the treatment, the cumulative exposure to the antipsychotic, the dose, the duration of treatment, the potency of the blockade, and then if someone previously had any acute motor symptoms, which historically we used to call EPS, which I'll describe in a minute why we shouldn't do that, but it'll be akathisia, dystonia, or Parkinsonism. So everyone's at risk, but these are the people who are more at risk if they're on an antipsychotic. If you want to know about severity, don't look at the total AIMS score, because let me tell you, AIMS ain't nothing but a number. That may be my corny dad joke phrase, but the APA agrees. In the guidelines that were just released, they even say, no specific score on the AIMS or DISCUS suggests that you should intervene or should not intervene, because the same total score could be different for different people. Think of it this way. Someone with an AIMS of a 2 in the mouth or lips, something like that, the tongue, it could be relatively irrelevant to them in some certain aspects of their life. But think about a musician. Let's say Mariah Carey, if she got an AIMS of a 2 in her lips or her tongue, I would think that'd be about a $400 million case of the AIMS, because that would be career ending. She wouldn't be able to fulfill her record contracts. So AIMS severity cannot tell you the quality of life impairments that person has. You have to personalize and individualize the severity based off of what they're going through. We have to move from this outdated view of looking at the AIMS 1 through 7 total score as being a marker of mild, moderate, or severe, and move towards a biopsychosocial formulation, looking at their awareness and incapacitation due to the movements. The movements are incidental. The actual quality of life is what we need to focus on. TD can't be put into a box because it is so heterogeneous. You can see the video of patients with TD over on the right. Most commonly, the movements are orobuccal-lingual in the lower third of the face, but it can present anywhere in the body as listed there. What's not listed there, but still a potential target for TD, are muscles we can't see, like the diaphragm, the esophagus, the soft palate. The movements themselves are irregular. They have motionless intervals. So if you don't look long enough, you might miss it. That's the value of those structured exams, or even semi-structured. Look at them for long periods of time, because they might not be moving when you're looking and looking away, looking at your notes, things like that, but you keep your focus on them. They can have very widely variable presentations. You saw just in these videos, creiform movements, dystonic movements, tick-like movements. They can look like almost anything. And the severity can be different in different body areas, as Jeremy had talked about. One key thing is we have to differentiate TD from drug-induced Parkinsonism, and don't call it EPS. Everything that moves could be called EPS, whereas not everything that moves could be TD. Also, things that don't move could be the EPS as well, like Parkinsonism. This video is of a gentleman with drug-induced Parkinsonism, and usually Parkinsonism is a lack of movement. It's hypokinetic movement disorder. But as you can see, there are a couple islands where he does have some hyperkinetic movements, the hands and the mouth. So I can see how clinicians could get confused and think, well, is that TD? Look at the rest of the picture. There's very few movement in the rest of his body. I can hardly blink whatsoever. It looks like he's been facially Botoxed. Also, look at the rhythmicity. It is perfectly rhythmic because it's a tremor. Tremor is not a dyskinesia. Dyskinetic movements are irregular, whereas tremors are regular and repetitive. Tick tock, same thing. Also, if you can examine the patient, they will have rigidity, most likely with Parkinsonism. It could be cogwheel rigidity with a ratcheting, or it could be a lead pipe rigidity. It's important to assess. And finally, with Parkinsonism, you can see gait, different differences in the gait. It's shorter steps, decreased arm swing, and you don't see that with TD. They have a more normal gait, and the normal amount of movements, or possibly an increased movements in the rest of the body. It's so important to differentiate, because the wrong diagnosis is always going to give you the wrong treatment in any field of medicine. A key thing to remember is that TD develops later, months or even years, whereas Parkinsonism, weeks, but even maybe hours. And reversibility, again, like Jeremy said, it's usually irreversible for patients with TD, but Parkinsonism can improve, but it may take several months off an antipsychotic. The mechanism of action and pathophysiology, Jeremy's going to talk about that, but suffice to say, TD is a state of dopamine hypersensitivity, whereas Parkinsonism is an underactive tone of the motor areas. So if you take away the antipsychotic, it's going to worsen TD temporarily, potentially, withdrawal dyskinesia, as I mentioned, but it'll improve Parkinsonism. And then the treatments, as I said, the most important thing, anticholinergics will worsen tardive dyskinesia. They will not help it. They will help and are approved for Parkinsonism, Parkinson's disease, or drug-induced Parkinsonism, but will worsen, but will not help TD. VMAT2 inhibitors are the approved options for tardive dyskinesia, but a class effect of VMAT2 inhibitors, which we'll talk about again, is that they can cause Parkinsonism if the dose is too high for the patient's needs. So again, our key learning point is that it's critical to diagnose the TD or drug-induced Parkinsonism and not just call it EPS. EPS is a vague garbage bin diagnosis that we shouldn't use anymore. And some ways to differentiate are the time frame of onset, TD months to years, whereas Parkinsonism days to, or even hours to months. So now that we've looked at assessing TD, Jeremy, please take us through how to treat TD.
Yes, thank you very much, Dr. Chepke. I really do appreciate that. When we think about treating tardive dyskinesia, we have 2 agents on the market that are approved for the treatment of tardive dyskinesia, and those are the VMAT2 inhibitors. But let's talk about what a VMAT2 inhibitor is, kind of how tardive dyskinesia comes about, and what these agents are doing. As you can see from this slide, this is a cartoon of a neuron. We have a presynaptic and a postsynaptic neuron, and then we have the synaptic cleft there in the middle, and at the bottom you can see the dopaminergic receptors. And we think what happens when we use antipsychotic medications is that those receptors are blocked over time, and so the brain changes. It either upregulates or become hypersensitive, or a combination of the both. And so when dopamine acts on those receptors, what we are seeing is more of these hyperkinetic movements in these patients who are susceptible to having tardive dyskinesia. So in order to treat this, the vesicular monoamine transport inhibitors were developed. And when we think about the natural process of dopamine within the body, what dopamine normally does is it acts on the dopaminergic receptors. It goes across the dopamine transporter up into the neuron. From that point, it then crosses the vesicular monoamine transporter, goes into the vesicle, and it goes down and is released across the synaptic cleft, and the cycle continues. It's easier for our bodies to reuse dopamine than to make new dopamine. So that's kind of how this cycle goes. Well, what the VMAT2 inhibitors do is they are acting presynaptically with reversible inhibition of the vesicular monoamine transporter. So when that dopamine comes up back into that neuron and it tries to cross the synaptic cleft, the vesicular monoamine transport inhibitor prevents that. And so less available dopamine is to be released across the synaptic cleft, and therefore we see less activity postsynaptically. But again, the VMAT2 inhibitors are working presynaptically. Let's first talk about tetrabenzene. It is one of the agents currently approved on the market. And tetrabenzene is very similar to tetrabenzene. What tetrabenzene, how they created this product was taking the hydrogen, one of the hydrogen ions off of tetrabenzene and replacing it with deuterium. Now, deuterium is a naturally occurring, stable, non-radioactive, non-toxic isotope of hydrogen. What you're looking at here is that the deuteration slows the breakdown of the active metabolite. So again, you can see from the top compared to the bottom on the left-hand side that hydrogen has been replaced with deuterium. So tetrabenzene formerly has all of these kind of high peak to trough variations, which leads to some kind of decrease in tolerability for this product. When that hydrogen is replaced with deuterium, what happens is that it gets converted via hepatic carbonyl reductase into its active metabolite. Well, the deuterium is much harder for the 2D6 system to chew up and spit out. So it really allows that metabolite to stay in the body for a lot longer and have more activity prior to conversion to the inactive metabolite. So it's this deuterium that increases the half-life and reduces these peak to trough variations that we saw with oral tetrabenzene. Tetrabenzene is indicated for adults with TD and chorea associated with Huntington's disease. Its contraindication for suicidality is truly an untreated depression in Huntington's disease. Hepatic impairment, concomitant use of reserpine MAOIs, tetrabenzene, or valbenazine. In terms of how to dose this product, we start at 6 milligrams twice a day, and we increase that by 6 milligrams weekly as tolerated. It wasn't studied in the patients with any type of renal impairment, but patients that are strong, that are 2D6 poor metabolizers, or that are on strong 2D6 inhibitors, the maximum dose is 36 milligrams per day. Let's take a look at the efficacy of tetrabenzene as well. The first data set that we see here comes from the ARM-TD flexible dose study. And what you're looking at here at a 12-week time point is a 3-point reduction on the AIM score. And again, I want to echo what Dr. Chepke said earlier. AIMS ain't nothing but a number, because this is really just something that we're using to evaluate the perceived hyperkinetic movement reduction in the patients. It's really not telling us truly about how these medicines are affecting their lives. When you look at this, the mean dose of tetrabenzene in this clinical trial was 38.8 milligrams per day. Let's take a look at the ARM-TD data. And when we look at the AIM-TD data, when we look at the AIM-TD data, this is from a fixed dose study, and this is going to be a placebo-controlled trial. And what we see here at the end of 12 weeks is that the 24 and the 36 milligram showed about a 3-point reduction in the AIM score at 12 weeks. And really what we're looking at is 2 times as much reduction in the AIM score versus placebo. When we look at the safety and tolerability of tetrabenzene, this slide is a busy slide, so let's look at it this way. The highlighted in yellow are really only going to be side effects that occurred at a greater incidence in patients taking tetrabenzene than in patients taking placebo. And so a well-tolerated agent. But the other thing that we need to think about is how often are patients discontinuing this product due to side effects? And we're looking at only 1% more in the tetrabenzene arm compared to the placebo arm. So we have a well-tolerated agent that not many patients are discontinuing due to adverse reactions. Now, this is the long-term tetrabenzene data, and this data is the longest data looking at tardive dyskinesia that we have available to us to date. This is an open label study, so there is no placebo control here. And these are looking at patients from both the ARM and the AIM-TD trials. And what you're seeing is about a 6.6 mean reduction in the AIM score at nearly 3 years time for this product, with a mean dose of around 39 milligrams per day. When we think about tetrabenzene and tetrabenzene, we also need to think about valbenazine's relationship to tetrabenzene as well. Tetrabenzene has alpha and beta metabolites that kind of go all over the body. And truly the metabolite, the RRR that you can see highlighted in gold here, is the alpha plus metabolite. This particular metabolite is the most specific for VMAT2 activity, and it has the least off-site activity out of all of the metabolites of tetrabenzene. So what valbenazine has done is it was reverse engineered by binding a valine amino acid co-bondedly or covalently to this particular molecule. And so when it breaks down, it becomes this active metabolite that is very specific for the treatment of tardive dyskinesia. When you look at the indications for valbenazine, what you're looking at is adults with tardive dyskinesia. Its only contraindication is hypersensitivity. And in terms of dosing, I'm very pleased to talk to you about the dosing today. There are some very unique things. If you look, first I'll tell you, if you look at the package insert, it says start at 40 milligrams for a week and then move up to 80 milligrams. Now this agent has been studied in the Connect4 trial, where you can start at 40 milligrams and some patients were deemed appropriate to stay at 40. In the package insert, which was updated in April of this year, April of 2021, there is now a 60 milligram dose. And so some patients are going to be it's acceptable to stay on 40 milligrams or move to 60 milligrams instead of 80 milligrams based on response and tolerability. So I think that the corporation will start marketing this product, the 60 milligram dose, around June 14th, which is in just a couple days. So this is fresh, hot off the presses information for you all. When you look at kind of dose adjustments, you're looking at strong CYP2D6 and strong CYP3A4 inhibitor use, where we might need to reduce the dose or stay at 40 milligrams. In terms of renal clearance, since we talked about that earlier, valbenazine does not undergo primary renal excretion, so there's no dosage adjustments necessary in patients with renal adjustments necessary. This is the data from the CONNECT-3 study. This is looking at the data here, and what we're seeing is a little more than a 3-point drop on the AIM score for that 80 milligram dose at week 6, which is statistically significant. We see nice reductions with the 40 milligram dose as well. This looks at the safety and tolerability. Much like tetrabenzene being a safe and tolerable agent, we're also seeing the same signal with valbenazine. There's one side effect on this chart that is greater than 5% and twice the rate of placebo, and that is valbenazine, or that is somnolence. None of the other side effects meet that metric, so we have a well-tolerated agent with valbenazine. When we look at the long-term data for valbenazine, we're looking at 2 clinical trials here, CONNECT-3 and CONNECT-4. And both of these long-term data sets are going to follow the patients out to 48 weeks. And these are open label information. And when we look at this, what we're seeing here are reductions in the AIM score anywhere from, say 4 or 5 points down as low as 10 points. And when these patients were removed from the medication at week 48, their AIM score in aggregate returned toward baseline. And there were no new safety signals or concerns that emerged during this study. Since these patients had their AIM score return toward baseline, what we need to understand is that these medications that we use for the treatment of tardive dyskinesia are treatments and not cures for tardive dyskinesia. Let's look at the evolution of TD treatment. So at first, I'm going to tell you is that tardive dyskinesia was first described in the literature before man walked on the moon. And we had no treatments until 2017 when valbenazine was introduced to the market. So we had to do something, or we had to try something to treat tardive dyskinesia. So we thought, hey, maybe we could remove the antipsychotics, or we can reduce the dose, but that's not always a great plan because we have to worry about stability of our patients. Or maybe we could replace one agent with another agent that has some less D2 antagonist, or is less potent on that D2 receptor site. And this probably isn't a great thing to do either. So we had to look at other options like off-label treatments. And so they thought, well, what about ginkgo biloba, clonazepam, even using benztropine, which actually and often can worsen the symptoms of tardive dyskinesia. So really, we've really had nothing for this in the past. So historically, we've been managing tardive dyskinesia very poorly. So the APA recommends that patients with tardive dyskinesia be treated with a VMAT2 inhibitor, right? And they also recommend that we should be considering this in our patients with mild TD. And when you look at the agents the APA recommends, they're going to recommend valbenazine or tetrabenzene over tetrabenzene because of the greater evidence associated with valbenazine and tetrabenzene, and probably the unfavorable side effect profile that we see with tetrabenzene. The next slide that we see here is a very, very busy slide. So without belaboring this slide, I thought we should look at it this way. The level A recommendation are the new generation VMAT2 inhibitors, and the new generation VMAT2 inhibitors are tetrabenzene and valbenazine. The level B recommendations are going to be clonazepam or ginkgo, and then level C, both with amantadine or deep brain stimulation. And if you turn your attention to the purple box on the left-hand side of the slide, you can see here that tetrabenzene should be considered only if both deutetrabenzene and valbenazine are not available. So let's talk about the key learning point here. And I think that I've reinforced this, but it's really that deutetrabenzene and valbenazine are generally preferred over tetrabenzene because of the greater evidence base supporting their use. And this is consistent with the APA practice guideline for the treatment of patients with schizophrenia. At this point, I'm going to turn it back over to you, Dr. Chepke, to talk about the real world considerations when we're treating patients with VMAT2 inhibitors.
Thank you for that awesome review of the clinical data, Jeremy. That was really great. So what I want to do is dive deeper into the mechanism of action and how that can help us to actually guide our real world usage. So we're probably all familiar with this graph. This is a pretty common one we all see in training, that for antipsychotics, that there's a certain threshold, loosely defined at about 60% of postsynaptic D2 occupancy. That's the minimum that most patients will need to get a therapeutic benefit from the antipsychotic. And then if you get too much blockade, though, as you increase the dose, you're going to reach a threshold where you're just accruing more side effects most commonly. And that could be prolactin elevations or the acute motor side effects, the EPS. So you want to keep it in that sweet spot. Now, there is no defined therapeutic window for VMAT2 inhibitors, so I kind of created one. Don't pay attention to the percentages on the y-axis because we don't know what the percentages are exactly, but just conceptually, I think of it that we have a therapeutic window for VMAT2 inhibitors as well. Too low of a dose and you're not blocking enough VMAT2 and you still have too much dopamine flowing through to reduce the abnormal movements. But then if you have too much VMAT2 inhibition, then you're going to have a lack of dopamine transmission, and that could produce drug-induced Parkinsonism. So another way to think about this conceptually is that with TD, the brain is metaphorically overflowing with dopamine because of that hypersensitivity that Jeremy taught us about. And so what we need to do is get the amount of dopamine flow correct. So I think of it like a faucet. And so you twist the knob on the faucet and that reduces the amount of flow because it's, as Jeremy said, presynaptic. So you're reducing it from the top down. So you reduce the flow to get it to the right amount for that patient. Now, if you reduce it too much and you cut the faucet totally off, well, the brain's going to dry up, and that metaphorically would be the Parkinsonism or potentially other adverse reactions. As we talked about, TD is so heterogeneous, there's not one correct medication or one correct dose that's going to treat everyone's TD. So we need to think about tuning the treatments for the individual patient. If your patient's TD is at KISS 95.1, you want to be able to dial the treatment into that station specifically. You don't want your treatment to be stuck at 107.9. You don't want it to be stuck at 89.9. You want to be able to adjust it, as we talked about in that previous diagram, to meet their individual needs. So some common adverse reactions to both of the VMAT2 inhibitors, as Jeremy walked you through, could be sedation. Now, sedation in most cases is time limited, fortunately. So in that case, you can reduce the dose until it improves. So turn the faucet, open it up, back up a little bit. Another way that you can manage this that I've been able to do is actually by reducing polypharmacy. The patients are on other sedating meds, especially sleeping pills, that they may not need if they do get some sedation as an adverse reaction, like trazodone. I've been able to take that away in some patients while holding the VMAT2 inhibitor dose constant, and the patient's daytime sedation has improved. Anecdotally, if a patient does have some sedation with valbenazine, the numbers there were a little bit higher than deutetrabenzene. I have seen anecdotally that people can do better on deutetrabenzene, but again, your mileage may vary, your patient's mileage may vary. Now, if you get to the lowest approved dose of a VMAT2 inhibitor and the patient is still exhibiting adverse reactions, work through it with them. That's in the importance in that purple box where it talks about educating your patient before starting treatment, because that lets them know that, hey, this treatment is going to work most likely. If you have some problems, we can figure it out and work through it. For valbenazine, you go off label and do every other night because of a long half-life, and then deutetrabenzene. In some cases, I've gone off label and used just treating at night and not giving the morning dose. Akathisia and Parkinsonism are conceptually similar. Again, it's by too much reduction of the dopamine flow. And these two could happen with VMAT2s just like they can happen with dopamine receptor blockers like antipsychotics. Akathisia most often is titration dependent, how fast you titrate them up. So if you turn that faucet down too quickly, that could cause the akathisia. In that case, open it back up by lowering the dose and symptomatically treat them. And what I like to use is propranolol and or mirtazapine. Those work quite well. And then after the akathisia improves, then you can rechallenge them with the higher dose if they're not having efficacy at the lower dose. Again, same potential off-label recommendations if the lowest dose still has some of those side effects. And then Parkinsonism, generally dose dependent. So once again, just reduce the dose a little bit. You don't have to take them off of it completely in most cases, although you may for some patients, depending on their situation, but try to just reduce the dose. Like I said, work around the side effects. It's worth it. How do we know it's worth it? Well, seeing is believing. Take a look at this patient. She was on a VMAT2 inhibitor for TD and it was withdrawn with her consent for the filming. And that's the before video. It was restarted and the after video is 24 hours later. Look at the difference there. Now, this woman has a more severe case of TD. This is not the bar that we should judge. We should only treat TD if it's at this threshold. But the point here is that you can see the difference. You do not have to be a movement disorder neurologist to see these differences. Yes, she does still have abnormal movements in the after video, but it is significantly, dramatically better. And we're not, again, as Jeremy has said, we're not looking at just scoring the change in the movements. That's irrelevant. What would be relevant is if we could hear this woman talk and her life change because of the decrease in the movements in the after video. That's what's important. But ultimately, if a picture is worth 1,000 words, a video is worth 1,000,000, and this it definitely tells us that we can see the difference with treatment with VMAT2 inhibitors. So if I can sum things up, it is our absolute duty to identify TD in everyone who has this condition. We caused it, intentional, unintentional, it doesn't matter. It's our duty to find it. And that's whether they're in our office or across a telepsych screen. The standard of care doesn't change because of telepsychiatry. In order to get to the real impact of TD from the patient, we have to have a strong alliance built with them so they can share their concerns, because if they don't feel they can open up to us about that, we may not get some of the true quality of life impairments. The goal of the treatment is not just to reduce the abnormal movements, as I just said. The goal is to reduce those so that the patient can have biopsychosocial improvements in their life, hopefully. And one last point is that as mental health clinicians, there are so many things in our patients' lives that we can't change, that we're powerless to change. If they are homeless, if they're unemployed, if they're being abused or from an abusive background, the list goes on. I mean, sometimes we just feel so powerless, right? But TD is not one of those things anymore. With the advent of VMAT2 inhibitors, we can treat TD now. That makes it, to me, an unnecessary burden that our patients do not have to face. And it is every patient's right to have the dignity to control their own movements, in my opinion. So this concludes the main part of our presentation. And now we're going to have a case discussion and then move into the question and answer period. I want to present to you an actual case from my practice. This was a 67-year-old woman with bipolar disorder. She didn't come to me for abnormal movements. She came to me with a chief complaint of depression. But I saw movements. I saw involuntary movements in her hands, some piano playing, and some oral buckle movements. And I thought to myself, I wonder if those two are related. She hadn't been on antipsychotics for years, but I did an Ames exam, and the total score was a 5. Now, Jeremy, how would you categorize this woman's severity of TD based off of that Ames?
You know, Dr. Chepke, I feel like you're setting me up for failure right now when you ask me that question. And I think really what we need to think about is not perceiving the Ames score as a number, much like you said, the Ames score ain't nothing but a number. Really what we're looking at is the functioning for the patients. And without knowing about how this Ames is impacting the function of the patient, I would have a hard time rating this. The other thing that I just wanted to make note of, when we look at things just as a number, right? Our patients oftentimes will underreport the severity of the TD. If we think about patients that, we do an Ames on them, and then we notice the movement, that really should be a dead giveaway to us that these patients are hiding these movements and they're ashamed of them. So with that being said, Dr. Chepke, why don't you tell me about how this patient really looked with an Ames score of a 5?
Exactly. And that's the key that I want everyone watching this to get across to you, is that what that 5 meant to her was that the reason why she stopped going to church was that the movements caused her to look like she was singing at the wrong parts. So she got in trouble with the choir director. And then when she was sitting in the church congregation, still going to services, the rustling of the paper in her hands made the other parishioners mad at her. So she stopped going to church altogether. And then her 4 and 5-year-old grandchildren, they called her a monster because of the facial grimacing from the TD. And that's why she got depressed, locked herself in a room, and lost 40 pounds because she didn't come out for meals. So her TD, I judged as severe, and I treated her with a VMAT2 inhibitor. And regardless of what the AIM said pre or post, what it meant to her was that with treatment, she got out of her room, started playing with her grandkids, she went back to church and started singing in the choir again. So that's why we treat TD, not for the numbers, but for the patient's life. There are a number of other resources on the TD360 webpage that we would invite you to take a look at. And now we're going to move to the Q&A session. Thank you so much for being with us today. We look forward to interacting with you.
Welcome back, everybody. And I didn't lie, did I, when I said to you at the beginning of this presentation that we had two outstanding presenters talking about a very important topic. Well done, Dr. Chepke. Well done, Mr. Schreiber. And before we jump into Q&A, please be sure to answer the post-activity questions to the right side of your screen. Please click the Submit button after the last question to successfully submit your answers. And as always, thank you so much for answering the polling questions. So, our audience has some really good questions for you, so let's jump right into it, gentlemen. So let me look at the very first question. So here's the question. And perhaps, Dr. Chepke, you can get the ball rolling. Is there a benefit to trying a different VMAT2 inhibitor if there is no change in symptoms with the first trial, assuming that the first trial was for the right dose, with the right dose, and for the right duration?
Yeah, thanks for the question, whoever asked that. And thank you for your moderation today, Rakesh. I think that there definitely would be a indication to try a second VMAT2 inhibitor if the first did not give a response. There's a lot of things we don't know about the pharmacology of the medications. There could be things there that could allow us to have a response when the first one didn't. And also beyond that, perhaps metabolism could have made a difference. The two VMAT2 inhibitors have some differences in their metabolism. And if you don't know their pharmacogenomics, or if maybe some drug-drug interactions were overlooked in terms of inducers, potentially, that could allow us to have a differential response with one versus the other. But ultimately, it comes down to me for, of course, we have to try everything we can to help people with TD. And if that means trying two or however many VMAT2 inhibitors out there, anything to help them, then we've got to do it because they deserve that help.
Got it. I think what you are saying, the way I hear it, is there are pharmacokinetic and dynamic differences that exist, and it's worth exploiting. I think that's what I hear you say. Thank you for that.
Absolutely.
Thank you. Jeremy, your thoughts. What do you think about what Craig had to share?
Well, first, I think Craig's answer was nearly perfect, if not perfect in and of itself. You're exactly right. And I think that we do need to try, and I think the patients need to be treated. And so if one medication doesn't work, we can try a different medication. It's not like that's an uncommon practice in our field anyway, where we try one medication. How many times have we tried one SSRI? It didn't work, so we went to another one, right? And so I think that would be something that absolutely we should do if we don't see benefit with one agent, to try another agent as well.
I think that's great. Well, I was hoping for a very long Q&A with you folks, but I'm being told that we just have run out of time. So apologies for not being able to interact with both of you, but you two are such stars in the field, and I'm just glad you're part of the Elevate family. Thank you, both of you. And
thank you.
Yes, my pleasure. No,
Pleasure's
thank you.
ours. Thank you, everyone.
Thank you. So before one of our attendees leaves, please be sure to check out the keynote session coming up next. Please visit the live agenda page to see the full session details and enjoy the rest of the conference. And goodbye, gentlemen.